You know, it's kind of weird how Cheryl got that pelvis inside, because this incorporates some, obviously, plenty of hip musculature, but also some knee stuff too. So, you know, yeah, they don't care about joints; they just worry about the soft tissue. So, all right. So, surface anatomy. We got crests, ASIS, inguinal ligament, which will be the top of the inguinal triangle. We'll talk about later. Rectus femoris, obviously patella, vastus medialis. Hopefully we've got some quads in here that look like that. Sartorius, other adductors, pubic crest, rectus abdominis. Glute med, going to be really, really important. We'll try to talk about that, the importance of that for the knee as well. Obviously for the hip, across the hip, but really important for patellofemoral and knee issues as well. Greater trochanter, most lateral part of the hip, real prominent there. Vastus lateralis, iliotibial tract. Anybody had IT problems before? Yeah, I had a lot of fun. Hard to treat. Hard to treat. Erector spinae, we were good there. You guys know that. PSIS, the two dimples here. Iliac crest, you guys can find that. Glute max, sacrum and coccyx, gluteal cleft, gluteal fold, hamstrings, tendons, popliteal region. We are going to skip over the palpation part and do that tomorrow. But if you look at it from a bony standpoint, think of the pelvis as kind of like a big bowl, like a salad bowl, okay? It can tip forward, anteriorly, posteriorly. We can hike it to one side, hike it to the other side. There's lots of things that are influenced by that. Our gait cycle, when we run, when we squat, all these things impact how your pelvis is going to move. Got a better picture here. Here you go. If you go to the acetabulum and you look at from a lateral view and you divide it into thirds, this is what's going to give you the delineation of the three parts of the pelvis. The ilium be this top third here. I'm talking thirds here at the trusty laser. So the third of the acetabulum. So obviously the ilium is the largest part with the big wings here. The ischium is more posterior. Ischial tuberosity here is where our hamstrings are going to originate, and then the pubic bone in the front here, the anterior. And of course it's symmetrical on the side. If we look from a frontal view here, lots of bony prominences. Now, different than anywhere else because these are bigger structures, right? These are a lot of times deeper structures, but I think easier to palpate on most folks, unless you get somebody really big, because the prominences are bigger. We're talking about bigger bones and so forth. So again, when we get to palpating this tomorrow, make sure again everybody's got shorts and all this stuff. I think it's easier palpation than talking like the wrist and all that kind of thing. Oh, so we got a lateral view here, kind of an anterior view. Bony landmarks, gotta know these people. It's gonna be where all your muscular attachments are gonna be. Again, you've got some nervous tissue to think about as well. You've got a sciatic notch. You've got some obturator foramen and things like that that's gonna house both soft tissue and nervous tissue. The sacrum and coccyx, we really didn't talk about it in spine because they saved it for this part, which is fine. The base of the sacrum is the top, which is a little bit odd, kind of like our heart. Base is here, articulates with the lump L5. You've got sacral foramen here. The apex of the sacrum, obviously the base is at the top, the apex is going to be at the bottom. And then you've got the fused vertebrae, the coccyx here, most inferior. We'll talk about the ligamentous structure later. Bony landmarks of the femur. Again, you can imagine the amount and the depth and the sheer magnitude of the soft tissue here. Biggest things we need to really look at: greater trochanter we talked about, most lateral part of the hip here, the head of the femur, the neck, site of majority of fractures that occur in the femur. You'll see a lot of hip fractures. If you're dealing with geriatrics that they fall on the outside of their hip, that is where they're gonna fracture right here. Sometimes they'll get a crushed head too, but they can replace that whole thing now, so it makes it a lot easier. Lesser trochanter, you're gonna have your adductors here. Intertrochanteric line, you're gonna have attachment here. Shaft of the femur. Again, longest bone of the body, biggest bone of the body, really thick as well. Difficult to fracture, except at the neck, I would say. You see many femur fractures, other than like a neck fracture?
Yeah, I do.
Motor vehicle accident.
Falls itself.
Yeah. So if we go distally, you've got this area for the patella. It's going to be a nice little groove here for this to go. Lateral condyle, medial condyle, you have epicondyles just moving superior to that. So again, huge bone, lots of muscle attachments, which you're going to get to enjoy here in just a few minutes. Again, we'll go through the palpation tomorrow when everyone is here, and we are dressed more appropriately. Muscles, lots going on here. I will give you a break, and you just need to know that there is a pelvic floor musculature. I don't feel like that's an entry-level task, so again, appreciate the photo, know that they exist. We'll talk more in depth about this in the fall with a guest lecturer, but I don't have a whole lot to add there. Just joint actions, I think you guys know these by now. We've got hip flexion, extension, and again, regardless of what the knee is doing, look at what the hip is doing. So this is also hip flexion and hip flexion, right? AB and abduction, or no, I think they go rotation next, yeah. So rotation, lots of ways to look at this now. Again, don't look at the knee. So while that is external rotation or lateral rotation, this is also lateral rotation, okay? So again, don't get fooled by what the knee is doing. Look at what the hip is doing. Internal rotation or internal rotation, okay? Tend to see students get this mixed up on occasion. Maybe an adduction, that's pretty easy. We'll talk a lot about the musculature involved there. And then you got hip flexion and extension, pretty obvious. But then in a closed chain situation with the flexed knee, you can have medial and lateral rotation of the knee. We're gonna talk about that in the gait cycle a little bit. When you hit on the heel strike and you go into stance phase, you will get some rotation that occurs at the tibia, okay? But that's only gonna happen when the knee is flexed and when it is in contact with the floor, okay? Or the ground, I should say. All right, get ready for the muscles, folks. Here they come. Rectus femoris. We got a quad here, right? 4 muscles, we all know quad muscles, but do we know all 4 of them? Only one is gonna cross the hip joint. That is gonna be your rectus, okay? Big muscle, huge muscle. And the front part goes all the way up and attaches at the AIIS, the anterior inferior iliac spine, okay? Bless you. You've got vastus lateralis, medialis, and intermedius surrounding this, but they are not going to cross the hip joint, okay? So we've got rectus, let me go ahead and put the next slide. Rectus action, extend the knee, yes, but also flex the hip, okay? If you haven't, I haven't said this yet, the coxal joint, C-O-X-A-L, also is kind of the fancy name for the hip joint, and the tibiofemoral joint for the knee. Yeah, I don't think you're ever gonna hear somebody say that, but you'll see this referenced in textbooks and literature reviews. Origin. Rectus is gonna come all the way down, or excuse me, originated AIIS like we talked about, and they all will come down and insert at the tibial tuberosity via the patellar ligament or patellar tendon. You're gonna hear people say, I think you'll hear them say patellar tendon more often than you'll say patellar ligament, but it's actually a ligament. It's gonna connect the patella to the tibial tuberosity. So it's bone to bone. So technically it's a patellar ligament. You will hear patellar tendon. I say it all the time. You probably say it as well. Vastus medialis is going to come down to the medial lip of the linea aspera, lateralis to the lateral lip, gluteal tube, and the greater trochanter. Excuse me, these are where they originate, not where they come down to. Sorry. And intermedius, anterior lateral shaft of the femur. Again, all of those will insert at the tibial tuberosity and innervated by the femoral nerve. Obviously, super important muscle group for function, things like squatting, running, kicking, going up and down stairs, all these types of things are going to be responsibility of the quadriceps as a muscle group. Struggling. Okay, so biceps femoris, semitendinosus, we got a misspelling here, correct that. Semimembranosus. These are your hamstrings. All are going to originate at the ischial tuberosity and then come down and insert below the knee. Lots of functions here. Biceps femoris. This is a big one that's going to go laterally. They can flex the knee, that's pretty obvious. Here's the hard part to see. They can also laterally rotate and extend the hip, and the long head also can laterally rotate the hip, okay? Tilt the pelvis posteriorly. So if you have, especially a fixed leg, and you can isometrically contract your hamstring, you can posteriorly rotate that pelvis. Happens a lot during a running cycle, which I'm so glad to see so many of you running on Saturday. Long head originated ischial tuberosity, short head at the lateral lip of linea aspera, right in through here, and inserts at the head of the fibula. So again, this is the most lateral hamstring. Long head and short head, both innervated by sciatic nerve. Semitendinosus. Note the spelling, people. So that's y'all's favorite. Obviously can flex the knee, medially rotate the flexed knee, extend the hip joint, up to medially rotate the hip, and tilt the pelvis again posteriorly. Again, at the ischial tuberosity for the origin. Proximal medial shaft of the tibia at the pes anserinus tendon. So pes anserine is a tendon, medial aspect below the knee, and it's going to have three muscles that will make up this: sartorius, semitendinosus, and gracilis. always remember, short-term goal for Pez's right. Very common area because you've got a bursa there. You're gonna get swelling. Easy to get tendonitis. Lots of inflammation will occur there. It really can be a source of any of those or the bursa. Semimembranosus also can flex the knee. And again, this is a medial hamstring. So it medially rotates, extends, and medially rotates the hip. This comes down to the medial condyle of the tibia, not quite to the pes answer. Inside of nerve there. Again, we will palpate these tomorrow. Your glutes. Gluteus maximus, the largest one, moves a little more laterally. Definitely a hip extender. Can laterally rotate the hip because of the orientation of the fibers in the insertion, and can abduct the hip. The lower fibers can actually adduct the hip as well. You see how it kind of has two insertional points here. It's going to originate at the coccyx, the edge of the sacrum, so just think lateral portion here. Posterior iliac crest, sacrotuberous and sacroiliac ligaments. They're all going to be located laterally here. It's going to move inferior laterally and attach at the IT band or tract, the upper fibers, and then the gluteal tuberosity with the lower fibers. Hence that if you look at it, it can abduct as well as adduct. Kind of like the deltoid was, if you think of it that way. Innervated by the inferior gluteal nerve here, L5 to S2. Medius. Again, really, really important for the function of the patellofemoral joint. We'll talk more about that. But all of its fibers can abduct the hip, and that's what you'll really focus on when you are trying to strengthen the gluteus medius, is to give them hip abduction exercises. Anterior fibers can also help to flex the hip and medially rotate. Posterior fibers can extend the hip and laterally rotate. But again, the majority of what you're going to see when you're thinking about gluteus medius is going to be hip abduction. Minimus, a little bit smaller, a little bit deeper. Again, abduct the hip, medially rotate, and flex. Gluteal surface of ilium to the greater trochanter laterally. Adductor magnus. If we look at the adductor group, you know from your medical terminology that magnus is going to be big or large. So this is the largest of the adductors, responsible for obviously adduction of the hip, but also medial rotation, and can flex the hip as well because it's more anterior. The posterior fibers, however, can extend the hip. Again, the majority of what you're going to see with this is going to be adduction and internal rotation. Innervated by the obturator and sciatic nerve. So now we become a little more anterior. We're going to get a little bit different innervation. Adductor longus. Again, adduction, medial rotation. Also can flex. Comes off the pubic tubercle to the pectineal line, so that mid shaft, the medial lip of the linea aspera of the femur. Again, obturator nerve here. Brevis. obviously brevis means shorter. Same thing, same actions. Inferior ramus of the pubis, pectineal line, and medial lip. More proximal here. Again, obturator nerve for innervation. Pectineus, even more proximal, very thin. Superior rami, pectineal line of femur, femoral obturator. Got gracilis, it's the long one, again, part of pes anserine. It's like a ribbon, comes down this way. Inferior ramus of pubis to the pes anserine region, again, obturator nerve. Adduction, medial rotation, flexion. And because it does cross the knee joint, it can help to that medial rotate and flex knee. You see all these adductor attachments here. Again, you visually folks that want to see that kind of thing. Tomorrow when we break out models and so forth, make sure you take a look at this, especially on that one. You can see all the different attachments all the way